Hello and welcome to our Module 4 lecture. I'm Dr. Ashley Parks and we'll be talking through the analyze phase or analysis phase of DMAIC. This is when you think about DMAIC, our third phase of DMAIC, but really the intermediate step between starting to understand a process with measurement and really getting into implementing an improvement. And so this particular phase is, I would say, the most challenging, which is why I'm giving this little prelude, and the most, I don't know, I think there are many competencies and tools that we'll discuss and that are featured in our courses that are part of this phase. And so this is really a place where we can all shine as health services administrators, but it is analysis, right? It is data and numbers and processes and discussions with stakeholders. So before we dive into some specific tools, I want to talk for a minute about a systems thinking perspective and about the idea of the iceberg metaphor. So the iceberg metaphor says that the events, the things that we see happen, the things that bubble to the surface, if you will, we have a patient fall, we have a patient that's injured. Those are events, and those all come together and start to form patterns, sometimes wonderful patterns, sometimes concerning patterns. Those are the visible evidence of the systematic work we're doing and the system structures underneath. So if you have wonderful processes in place, if you're screening every patient that comes in appropriately for infectious disease, and you're doing a chlorhexidine wash for, high risk patients or whatever that clinical protocol might be, and you're following that protocol and you're updating it based on the most recent evidence, well, you're going to have fewer infections, ideally, on the nursing unit, right? Fewer healthcare associated conditions. So the idea that if we do a good job, we will see fewer negative outcomes and hopefully a lot of positive outcomes. Now, this can be a little bit of a struggle because the work that we're doing is something called below the waterline. So you can do a good job all day long, and maybe people don't necessarily see that work getting accomplished, right? They just know that no patient has fallen in the last month. They don't know that you implemented a fall risk protocol change, that you have, leadership rounding on the nursing units. They don't know any of those details, maybe. And so it's just everything is fine. And that can be frustrating for some of us that work in quality improvement, that no news is good news, right? You can work really, really hard on something. And if it's not something we're tracking aggressively, or if it's not something that's visible to everybody, it feels like, oh, well, I guess we never had that problem to begin with, right? And I hear people say that all the time, like, oh, I don't have to exercise, or I don't have to, worry about my health. I don't have to quit smoking because I'm fine. And it's like, everything bubbles up eventually, right? We end up with consequences of actions, either in the short term or the either in the short or near term or out into the future, right? And so when we think about working below the waterline, we have to be consistent. We have to be process focused, realizing that later on, sooner or later, the results will bear fruit, right? And the idea that if we're working in an iceberg analogy, there's a lot more work and process and groundwork and stakeholder engagement that happens before we see a change in necessarily behavior or outcomes in an organization. And so the main lesson here for us is that it takes time to make those changes. And then it takes a little bit longer to see those results. So we've got to be patient. We've got to be consistent. We've got to be mindful about how we institute change. Now, when we talk about systemic structure, what do I mean when I say systemic structure? These are the processes, the policies and procedures and protocols, the things that we say we are going to do and we follow through on. It's also the resources, our staffing model and our building. It's all the choices that leadership made now or in the past, and how that then frames the type of care that we're offering now. And so sometimes we do an assessment of an organization's, readiness to deal with a certain natural disaster or, preparedness. And that is really a review of the systemic structure. Do we have everything we need to have in place in order to have good outcomes? And so what we do as health services administrators is we go below the waterline. We work really hard to understand the history of our organization, to be aware of different types of mental models, different types of process approaches, right? Are we using the Malcolm Baldrige Award approach? Are we using something like our next slide, which is thinking about single versus double loop learning? Are we thinking about these theoretical approaches that help us frame in a mental model and make better decisions? And so when we integrate some sort of, and we're going to talk about loop learning in a moment, but when we integrate some sort of thoughtful intentionality into how we design the way we deliver care, right, we can hopefully expect better outcomes. So this slide here talks for a minute about the difference between single loop and double loop learning. Now, I don't want to villainize the concept of single loop learning. There are times when that's absolutely appropriate, and we'll talk about that. But the idea is we want to push towards this bottom option, double loop learning. So let's talk about these for a moment. Single loop learning involves us as professionals coming in and having certain assumptions. We have our biases, we have our backgrounds, and we have mental models that we're trained on, like DMAIC. We have approaches and tools that we understand, things like focused PDCA, which is another quality improvement methodology, and we have our values. And then we do something. We have our actions. Let's say we have a patient that's given a wrong medication. That's the action on the nursing unit. And there's a consequence, right? Patient is sick, has an allergic reaction, but hopefully is okay at the end of the day, right? But the consequence is that staff member may be counseled for giving the wrong medication. Well, single loop learning would mean that going forward, that staff member, that nursing staff, would change their behavior. They would try not to give the wrong medication. They might check a little closer. That is single loop learning. Oops, I got my hand burned. I won't do it again. Oops, I made a mistake. Won't do it again. Double loop learning is when we go back and make actual changes to the processes. We say, wait, how did you accidentally give the wrong med? So you had medications for two patients in your hand in two different cups and you handed them the wrong one? Why did you do that? What happened? Are you okay? Are they okay? What's going on? And we look at that behavior and we say, okay, what could we do to prevent that? Maybe it's some sort of education, but maybe there's also an administrative fix, right? Maybe you can only pull medication out for one patient at a time now out of our medication dispense system. And some of these changes make our jobs a little harder, but they keep us safer too. And so when I think about double loop learning, I think about, well, let's say we had an issue with documentation, right? Someone is documenting something inappropriately in the medical record. They're not filling in detail. Well, we can design an improved form that asks them very specific questions and forces better detail of the care for coding and other purposes. That's a loop too, right? That's a double loop learning. We're going to go back and adjust our processes. Now, sometimes double loop learning goes even deeper, right? Because you'll notice it's going all the way back to assumptions, mental models, operating values. Sometimes we have to change how we're functioning, how not just the action, but how we're perceiving ourselves and our patients. We need an attitude reset. We need a focused effort around redesigning this process. And so instead of just, oh, I won't do it again, or let's me change my approach slightly, let's redesign the form. Let's redesign the template. Let's hardwire the right way to do it. Let's go back and talk with other staff and design a better process. That revision piece that's so important to learning allows us to do a better job. And we've got to involve folks who are out doing this work, right? It can't just be, leadership decided we're going to change it. It has to be that engaged process. All right. So thank you for going down that road with me briefly. Reflecting on the analyze phase of Six Sigma, it's really important to realize that we've already done some of the work I'm going to talk about in a moment in the measurement phase. We defined the problem in the define phase, we measured it, and now we're going to analyze that data in depth. And you may say, well, what's the difference between this phase and the measurement phase? When we collected and looked at some data, we maybe made some charts and looked at some baseline data. Yes, but this is deeper. This is when you're tracking data over time. You are really looking at trends and you're preparing to implement an improvement, right? You're really reviewing that data and coming up with recommendations. So this is really quantitative, primarily. We have a lot of qualitative data too in healthcare quality improvement, but you're really looking at those numbers. You're looking at your metrics. So some of these tools, like a root cause analysis, involve talking with folks and figuring out why things happen, figuring out what a root cause or several root causes might be for an issue. We do those through different tools like a cause and effect diagram. Maybe we'll even do a broader failure mode effect analysis where we're looking at everything that could go wrong in a process. We generate charts like control charts, more flow diagrams that we already learned all about in the last few lectures, more Pareto charts where where we sort the data from the most likely cause to the least likely and focus on those key causal factors. But then we have these stats, you'll notice. We've got correlation analysis and hypothesis testing. We've got an ANOVA example, which is where you compare the mean score between three or more groups. So we're looking at maybe the experience across three or more nursing units. And then regression analysis. So these are all tools that we use. And I want to encourage you, if you're feeling excited about this and you're wondering, why is this not an Excel-based class? We do a little bit of that. We talk about that a little bit in quality improvement, but I don't force you to do statistics in a general QI course, right? I don't ask you to do linear regression in this class. This is not a statistics class, but if that's something you want to do that you're comfortable with, I encourage you to reach out to me and set up time to talk through those things because I do them all day, every day. I love to do research. I love to do QI improvement projects, and I love to use the math to tell a story, right? The statistics. And so I'm glad to look at sample data with you, do that work together. And there are other courses, of course, in the program where we do that together, where I teach about statistics and where you'll learn from other faculty. As far as the advantages of walking through these organized phases, one of the main advantages of the analysis phase is really definitive tools like regression analysis. When we're plotting out the relationship between nurse staffing and patient falls, when we're looking at some of those things up close, it gives us a really deep level of understanding of the data. We start to understand the various factors, and we begin to be better able to think through potential solutions. Also, this particular step allows us to think through the hypothesis testing phase, to think through not just developing a theory around what's happening and what we can change, but also quite often you unearth a story you didn't think would be there, right? Maybe let's say we're looking at medication errors and we're looking at all sorts of types of medication errors, wrong patient, wrong dose, wrong route, whatever it might be. You find that, with some of the patients, this was the causal factor. With others, it was another factor. So we're able to do that. We're able to organize the data and then think strategically about where do we invest our resources if there's lots of different things going on at once and a lot of different priorities, even in one focused project. And so these analytical tools are really important. I'm going to walk through a few of them. Before we do that, though, I want to talk about what it means to just look at the root cause of an issue. This is our Swiss cheese model, and I borrowed this again from Dr. Leiter's Basics of Performance Improvement text. This is the Swiss cheese model that looks at whether or not an error happens being determined by an alignment, kind of a perfect storm, if you will, of factors that line up. And I'll give you an example. And it's funny because this slide, I think, is referring to that exact same example that I've been through many times, or at least it could be. So this slide is meant to capture a potential error. And so this error can only happen to this patient if the risk management processes fail, the first slice of cheese goes through the hole. If the nursing processes fail, if there's no physician oversight, if we don't have our safety knowledge base and understanding of the process up to date, and if we're not information sharing and reporting to leadership. I'll give you an example, my example where this applies. I used to work as a director of quality and risk management for an inpatient rehab facility, an inpatient rehab hospital. And we had, a lot of work that we did to prevent patient harm. And one of the things that we were working to prevent was pressure ulcers, right? Or wounds, right? That can happen on the back or other places, on the bottom of the feet, anywhere that, is exposed to pressure and moisture. Well, we had a situation where a patient got a pressure ulcer and we didn't find out till they'd been in the hospital over a week. Well, at that point, it's considered A hospital-acquired pressure ulcer or a HAPU, a healthcare-associated pressure ulcer, is kind of the new term, but it's associated to us in the hospital. Well, the frustrating part is that this patient had had this pressure ulcer for a very long time. They'd had it before in the skilled nursing facility they'd been in before it was very deep. It couldn't have happened that fast. But we never documented it. When they came in, we didn't do the POA or present on admission paperwork. Nowhere did it say in any of the review that this patient had a pressure ulcer up until day 6, up until they'd been in the hospital almost a week, which meant that when they came in and the initial nurse did the assessment, the physician did their H&P, history and physical assessment, no one noticed this, which is a problem. And then every nurse on every shift, at least the way we did things, was supposed to do a skin integrity assessment. They were supposed to check the skin of the patient, which means no one did for 6 days. Also, we had a special protocol in place where we asked our physical therapists and our occupational therapists to also do this check. So if they were spending an hour with a patient, which they would do, normally most patients in that environment have therapy 5 days a week, 3 hours a day, quite often an hour of PT, OT, speech. If they didn't need speech, maybe 2 hours of PT, hour of OT, or vice versa. That meant that there was 15 times where their body should have been checked by therapy, in addition to every shift nursing checking, and no one checked, which meant every time someone didn't do that part of their work, and I'm not meaning to be blamed, but every time it was skipped, that was another slice of cheese. And so when you stack them all together over 6 days, that's almost, 30, 40, 50 pieces of cheese, people, situations, opportunities that were missed. And we never want to cast blame, right? If you have the right processes in place, they should be easy and doable for people to follow. But that was a situation where the Swiss cheese model really applied, and we had to really increase our focus on documentation around skin integrity assessment. All right. There are all sorts, so moving on into root cause analysis and the formality behind that, there are all sorts of tools we can use. There's several posted in our course. And when I say, I'm going to do a root cause analysis, it can be something as simple as asking the question why 5 times. We actually call it the 5 whys. I have some templates posted where we say, why did this happen? Why did that happen? And we try to drill down. Or we can build what we call a fishbone diagram or an Ishikawa diagram that goes over various causal factors. And we can use any grouping of factors we want, but this slide and the next slide are some popular ways to group them. You'll see it says manpower. Sometimes we call that people or personnel. Maybe it's factors related to materials or equipment. Maybe we didn't have the right equipment. The environment, maybe it's management factors like supervision and resources, factors related to our methods and approach, or the management system as a whole, training and operations. So these are examples of categories we could use to sit with a team and ask them, what do you think caused this issue? Why do you think that patient got a pressure ulcer? Let's talk about it. And there could be certain environmental factors, certain management factors. And so that's really what the purpose of this type of tool is to get to the 1, 2, 3, few, hopefully, key causal factors, the root cause of what happened, and to make sure we develop an action plan to address that. So we define the issue to be evaluated, such as a pressure ulcer on a patient or a patient fall. Quite often, they're patient harm related or accidental. We gather data and we can apply that 5 whys approach, right? Why did they get a pressure ulcer? Because no one checked and they were in bed flat. Why were they in bed, right, with no, appropriate bandage or wound vac or any of that, right? We ask those questions and keep drilling down. We brainstorm corrective actions and we develop an action plan to implement. Now, the simple example I'm going to walk through really quickly is a 5 whys example. And this is probably the most high level, brief, quick way to do a root cause analysis. And so let's say we're dealing with an issue and we get a bunch of nursing staff together to address that issue in a room. We're talking maybe during shift change. We can do this really quickly. This is different than developing a whole root cause analysis diagram, an Ishikawa diagram or fishbone, where we would maybe sit for an hour with everyone involved in the case. So This particular example that I'm going to walk you through involves nursing staff on an oncology unit noticing a high rate of IV infiltrations. So we're having that issue. It's requiring a lot of IV restarts on the unit. And I mean, we don't want a patient having, an infiltration where either their central line or whatever tubing we're using, right? Some oncology patients have ports, right? Some have IVs, depending on the medication. We don't want a situation where we've got blood or substances leaking back in or any sort of concern. So the question we start with is why? Why are the IV lines infiltrating? And they say it's because the tubing seems to be moving excessively when the patient moves. So the patient moves their arm, their body a little bit, tubing moves around. Why does the tubing move so much? It didn't before. This is a new problem in the last 4 weeks. Did we suddenly get some really rambunctious oncology patients? What's going on? I kind of laugh because right now I'm going through my second bout with cancer, right? And I'm not, I sit still a lot. So, right? So why would it move around, right? So the tubing seems to slip with movement of the IV site, is what they say. And to me, I'm like, okay, you just told me that, right? The tubing moves, but now we're saying, okay, well, it's really slippery. Why? Why does the tubing slip? And it says the tape that's holding the plastic tube is allowing it to move in between the piece of tape and the skin or wherever that location is. It's not holding it secure anymore. Why? Because the adhesive tape is not holding the tubing. Now, this is driving me crazy a little bit. If you look at this example, we're moving really slowly to that root cause. And so sometimes you don't need to move that so slowly. Sometimes you can jump a little bit ahead. But the idea is if we move from why does the tubing slip with the movement of the IV site, the tape that is holding the plastic tube allows it to slide in between why the adhesive isn't working. So it's the adhesive's the issue, not the tubing. Moving slow. Now, why is the adhesive not holding the tubing? And this is often where we end up at the end of these. Central Supply states they started buying tape from a different vendor, lowest bidder, last month. They tried to cut costs. So this happens a lot. We find that we try to shift costs to a new vendor and we end up with a sub product. And that's a real problem in healthcare supply chain. I can tell you probably off the top of my head, 5 to 10 examples, don't worry, I won't right now, of situations in my career alone where all of a sudden we had a problem and then I found out it was because we moved from an existing vendor for a service or a product to a cheaper option and the cheaper option didn't work. So this is how we do a simple root cause analysis. On the other hand, we can do a broader, more investigative root cause analysis, and we'll talk about that on the next slide, realizing that the whole point is to get to an answer. And so sometimes we want to leverage these tools. We want to be really detailed. Other times we don't need to be. So keep that in mind, right? Use the tool that fits what you all need. And sometimes we need to use a more robust tool. And so if we're analyzing an individual scenario, we would do a root cause analysis using an Ishikawa diagram. If we are analyzing a host of problems, let's say we have so many issues with getting patients admitted to the hospital floor, we may not use an Ishikawa diagram that looks at one or a group of patients' outcomes. We may instead do something that we're going to talk about later on called a failure mode effect analysis, which looks at every problem that could happen in a process, anywhere we could go wrong, and proposes solutions to each of those. So what could go wrong when we first bring the patient on the floor? What can go wrong with the paperwork? It looks at each step, and it's a little more hypothetical. It's not about one patient's experience. It's about everything that could go wrong. We call those failure nodes. So realizing that, I want to show you a quick example of an Ishikawa diagram. Some of these slides have some specifics about categories you could use, like methods, materials, machinery. But if you also read through this content in the course, you'll see that you have some flexibility. So this is the diagram, but you'll notice that the high-level categories aren't people, process, or manpower, machinery, methods. It's not some of those standard titles that we see in the QI textbooks. Instead, this is customized to the issue. This specific issue, and the issue is written at the top of the diagram, the fish's front, their face, if you will, is low immunization rates. So we have low immunization rates in our clinics. What's the issue? Is it access? Is it cost related? Is it provider compliance? Is it patient adherence? What's the issue? And so we go through and plot those four main causes and then subsets. Access within a primary care clinic, vaccine availability, transportation, co-payments. We plot out all those factors. And so this is a more customized view. And you'll notice that I say here that you got to agree on the target issue, but once you have, you can decide, do I want to work with these predefined categories where every rib bone, if you will, in the fish, every piece is one of these methods, machines, people, materials? Do you want to do that? Or do you want to have those categories be more custom? And it's up to you and what fits that data. Once we've kind of mapped that out, we can distribute the category descriptions and start having this very open brainstorming session with our colleagues and say, okay, were there any people related factors that contributed to this issue? Were there any technology related factors that contributed? And then we can start filling in the diagram together. The brainstorming sessions should produce a lot of duplicate, similar ideas. We expect that, so we condense those down. And then we can also take this diagram and use it to analyze different situations as well. So we can say, okay, for this particular patient, this was the issue. For this particular clinic, this is why their immunization rates were low. Now we can take that and we can take all those causal factors and actually put them into a Pareto chart. And if you remember, the Pareto chart was the chart where we have an X and Y axis where we've got the volume of incidents that we contribute to each cause, and then in little bars, and then we've got our columns, right? And then we've got a cumulative percentage. So we're focusing on the most key cause that happens most often, all the way through the least often, right? So we're working from high to low. Now, that is an overview of some of the more, I would say, qualitative approaches we use in the analysis phase. We conduct a root cause analysis either using a quick 5 whys or using an Ishikawa diagram. But I'm going to quickly just pull up a few example slides. I'm not going to spend a lot of time in this space because we have not that this isn't important, but this is what you should be learning in your statistics courses and is out of the 10 people in the room, you may be the person running these stats for the meeting. You may not. I love that. I think all of you should aim to be competent across all of these domains, across all the competencies. I would love if all of you could run a chi-square analysis, right? Comparing outcomes. I would love it if all of you can do linear regression, right? And that's why I'm sharing these resources. But I also realize that it's not fair in a quality improvement course to make you do a linear regression in Excel today. So I want you to know I'm available here as a resource. I do this work a lot. I'm also going to share a separate video from a resource. I have a healthcare finance textbook, and I've done some resources for that textbook on how to do a linear regression in about 30 seconds in Excel. It's so fast. I can plot out the relationship between two variables and then give you an equation that maps that relationship really quick. Excel is amazing, and it's come a long way. But I want to say really quickly that we have to work with data all the time. And so knowing when to use what kind of statistical test and how easy it is can be really great. And so we may be looking at the relationship between two variables, for example, and we may do a Pearson correlation, or if it's ranked data, we do something called a Spearman correlation to look at whether or not two continuous variables are related to each other. So that's one method we use a lot. And if it has a strong negative relationship, it's close to -1, strong positive relationship, then you end up with an R, which is that test statistic that results of a positive one. And so I encourage you to explore some of these. I walk through some examples. Of course, we use linear regression, and then we also use correlation on data that can be put in a scatter plot like this. In the linear regression, we're often plotting that line of best fit, understanding the relationship between the X and Y axis. With Pearson's correlation, what we're trying to do is understanding mathematical relationship. This particular one has an R of -0.29, which means the number of errors per an hour and the number of claims per an hour have a slight negative relationship. Not enough that I would really call it anything significant. I can't see the p-value here, but enough what we know that when people work faster, the number of claims per an hour, the number of errors, so number of claims per an hour goes up, the number of errors goes down. Now, there's a couple reasons why I think people who are more proficient will work faster and do better. So I think that might be the secret here, but this is just some example data to explain the concept. Okay, so we've got some slides here about that. As I go forward, this talks a little bit about the point of a correlation, how we use this data to look at the relationship between two numbers. And then there's some slides that I've shared, again, relying on resources from a couple different management scientists and quality improvement experts. Again, this resource is from Dr. Leiter's Basics of Quality Improvement text. But he walks us through an example process in Microsoft Excel and how easy it is to plot two pieces of data side by side, run this simple equals Pearson, and then you choose them together, and it will literally generate the R statistic right there. You can also download the statistics pack in Excel, the add-in, and run the Pearson, and it will give you the R, it'll give you the R squared, it'll give you the P value, the significance value, all of it in one place. But again, I'm not teaching you stats today. I just want you to know in this phase, we're doing this work. So if this is something you really are passionate about and care about, I want you to know that you or someone on your team needs to be able to do some of this. Now, quite often we're not going into inferential statistics. We're looking at averages and how often things happen. Quite often we're thinking more about average length of stay and decreasing the total number of patient falls, not elaborate stats. But sometimes we are, and being able to do that work allows you to be more sure about any conclusions. And it also allows you to design some experiments. So it allows you to say whether or not something you're doing is working or not. So if you're planning for an intervention in our next phase, in our implementation phase, our improve phase, the next lecture, if you're going to plan to do something, to pilot a new idea, you want to make sure that you've set it up like an experiment, that you're following that scientific method and you're testing a hypothesis. And so the rest of this lecture really reviews some of those methods and approaches. Now, I do want to say, if we skip ahead for just a moment here, that I talk about hypothesis testing and all the math and stats, how to do a t-test, which is comparing averages between two groups, means between two groups, how to look at confidence intervals. And I know some of you are like, you already taught me this in another class. I know. That's why I'm not doing it now. But this is a great resource to save. Keep it on your computer, reference it later, because I know a lot of us want to use ChatGPT, but that is still a tool that is learning how to propose the right statistical test. So having this resource is really important. And analysis of variance compares the mean between three or more groups. So it's a broader version of what we see with the t-test. And then you'll notice, sorry, I'm almost there. I have some information about regression. But this is a slide I wanted to get to, multiple regression. Quite often you'll plot the relationship between two variables and it won't be the right variables, right? You'll be looking at staffing ratio and patient falls, and then all of a sudden you'll realize, oh, this isn't what's driving patient falls. We replaced the flooring 6 months ago. Wow, is that a factor? Right? All of a sudden you'll start looking at it differently. And so I just want to say that there is some statistical analysis that we can do, multiple regression, where we can plot it out like an equation. Y equals, mx plus b, you've seen an equation, but y equals mx plus c minus d. Like we can make an equation that has many variables and includes the impact of multiple causal factors. Do I do that as a quality improvement professional? Usually no, most don't. Have I? Yes, I have, but most don't. So my particular approach to QI is very data-based. It's very statistics-based because I'm a researcher, because I've worked in that space. But I'm that one person out of 10 in the room doing it that way. And so I want today, your little side assignment is to critically reflect. Are you the person in that room who would be doing these statistics? Are you going to be a clinical data analyst? Or are you the project manager leading the meeting? What is your role? What is your interest? Because if you're interested in this space, there are some really cool certifications and educational opportunities that we can talk about. Reach out to me. And you may want to work towards that. If you're not interested in this space, if you say, oh my goodness, math is not my thing, then it's important for you to gain a baseline competency, right? Enough to be dangerous, enough to lead the meeting, enough to engage, and then decide what your thing is, right? Do you want to be the person who's putting together the status reports, who's organizing the teams, who's leading the meeting? What is your role? What are those management competencies that you're really comfortable with? Because this isn't everybody's cup of tea, if you will. All right, well, that is what I wanted to cover today. Just a quick overview of the analyze phase. We are deploying and using all these tools. The one thing that you will most certainly do at some point if you work in QI is conduct a root cause analysis. All right. All right. Thank you so much for your time today. I know today's discussion was a little long, but I love sharing with you all. And I love hearing from you and having our one-on-one meetings and talking through how this is going to interact with you in your career and your development. So don't be a stranger, and have a great week.